Thank you. Thank you, Eula. Thank you, KIS Seminar Committee, and Dr. Hoffner for inviting me and giving me a chance to present some of our work on prostate cancer progression detection using magnetic resonance technology. I'll go through the different phases of the prostate cancer progression that we've been working on since I first started working as a postdoc with Dr. Karanovics here at UCSF, and my career also progressed slowly here at UCSF. So let's start with, as you all know, prostate cancer is the second most commonly occurring cancer in men and the fourth most common cancer overall, right? The pressing need facing clinical management of men with primary prostate cancer is an accurate method for distinguishing indolent from aggressive, potentially lethal cancer in individual patients. It has been shown that there is a clear prognostic value that delineates tumors with Gleason grade. That's the way in which a prostate cancer is assessed, or that delineates things, is a primary and a secondary score that ranges from 1 to 5. And a Gleason grade of less than 3+4 differentiates quite differently from that of 4+3, as shown in this work here. And so what is the motivation, right? The good differentiation non-invasively between these low-grade indolent prostate cancer from high-grade aggressive disease is very important to minimize overtreatment of benign disease and undertreatment of potentially lethal disease. Just to give you an example, that in the year 2020, there was 1.4 million new cases, of which only 25% of it was needed aggressive treatment. So the rest 75% did not need much of a treatment. So at that point, it highlights how we could absolutely minimize the cost and the quality of life that could impact the patients if we are able to clearly have confidence in distinguishing the indolent low-grade prostate cancers without constantly having to biopsy them. And so this also gives us confidence in the patients being selected for active surveillance and monitoring of disease progression. So our tool of choice is magnetic resonance technology, and I'll show you specifically looking at the baseline basal parameters, which is metabolism. So what is already known in the metabolic reprogramming that occurs in prostate cancers, like both benign and malignant prostate exhibits high glycolytic metabolism, limiting the FDG PET imaging. And also, the fundamental switch in cancer is the utilization of the carbons and not the uptake of glucose, which highlights that FDG PET has typically not been used. And additionally, the bladder being so close to the prostate severely limits its use in primary prostate cancer. So earlier works from Costello and Franklin has showed that in the normal prostate, a majority of the glucose ends up in citrate, and it's not used in the TCA cycle, and it ends up in the ducts and into the semen. With the onset of malignancy, though, the glucose carbons ends up in a combination of lactate, which is aerobic glycolysis, and TCA, and enters the TCA cycle with citrate, and additionally in the lipid and phospholipid metabolism. And this observation of citrate is feasible using proton spectroscopy. And this is routinely used at our center and many other institutions for care of prostate cancer patients. So it forms part of the multiparametric MRI that the patients are generally screened with. But as you can see, lactate is not really conducive for observation because it lies too close to the fat. But we decided to take a closer look at lactate in prostate cancer. We've done quite a lot of work, having worked with Dr. Karanovics in prostate cancer, studying the biopsy that we get from patients. And we've done high resolution magic angle spinning on these to quantify the amount of lactate. So we did a deeper dive and looked at the grade dependent lactate. It was significantly higher in those biopsies that were scored with primary pattern grade 4. And similarly, the LDHA expression was also high, the mRNA that we quantified. And so our goal is then to use the hyperpolarized carbon-13 to correlate the lactate production to the Gleason grade of the prostate cancer using a preclinical model system that uses the patient-derived living tissues in a small-scale MR-compatible bioreactor. So before I jump into what we did, I wanted to give a brief introduction to the tools as well as I go along for those who are not very familiar with hyperpolarized MRI. So because I heard the seminar, there are different mix of students as well as staff, as well as veterans in the field. So here you know that anatomical imaging, there are uses the water protons, right? That's the typical MRI that you would get when you go into a scanner. And the concentration of the signal arises from a concentration of about 110 molar of the water protons. When we start looking at the chemical composition or the metabolism, looking at proton spectroscopy, the concentration is only on the orders of certain, like tens of millimoles, that we are conducive to picking up with MRI technology because it's not highly sensitive. So that gives us a loss of 10 to the 4th lower signal. Additionally, if we go to the interested in looking at the carbon backbone, because the natural abundance is only 1.1%, which is the isotope that is MR detectable, and also the gyromagnetic ratio being 1/4, again makes doing carbon spectroscopy it's impossible to do in vivo. So we are all down by a factor of 10 to the 6. But this is enabled using this dissolution dynamic nuclear polarization technology. There are many components involved in this. I often like to show this to really put it down to the nuts and bolts without delving too much into the techniques. It requires C13 enriched substrates that is of interest to be studied, which is placed in a microwave in addition to radical. And then at very low temperatures inside the magnet, the polarization of C13 is then achieved, where you have increased the signal, and then upon rapid dissolution, the polarization is preserved and we can study it. And so this would give us over 50,000-fold enhancement. So what that implies is we are now able to be on par with proton spectroscopy with regards to carbon, but we are limited in the amount of time we are able to study this because it has a non-renewable signal lifetime, which is on the order of tens of seconds to a couple of minutes. But it enables us to study dynamic enzymatic processes in real time. And unlike proton spectroscopy, where we need to acquire for a really long time to get robust signal, here we can get a complete imaging data set in a couple of minutes. And the clinical application of this technology has been very well established. And some of the works coming out of UCSF, the clinical team has also shown that this particular technology is able to non-invasively detect cancer that has actually been not picked up by multiparametric MRI in prostate cancer patients. So this is the technology we use, but as you can see, it needs a living model system. And before we've used cells and biopsy tissues, but the biopsy material is so small that it makes it really difficult to use. So we then worked with our longstanding collaborator, Dr. Donna Peel, who is then at Stanford, and now we are happy to say that she's one of our colleagues here at UCSF. She is an expert at developing preclinical model systems, and she had already worked on these tissue slice cultures where you get a core from radical prostatectomy specimens, and they are used in the Crumdex slicer to be sectioned into 250 to 300 micron thick slices, and then while being immersed. And she also formulated the media which could keep these slices alive and viable and could be used over time. And so we used this platform to first verify, metabolically speaking, are these tissue slices similar to the other model systems that we had been working with? And so we did the metabolic profiling using high resolution magic angle spinning to characterize the intact tissue. So we did this in biopsies and compared it to the tissue slice cultures. Similarly, we also did extractions and compared it to the cells. And you can see that the metabolic profile of the tissues better reflect in the snap frozen in human biopsy samples than the preclinical cell lines, where the metabolites are extremely high in concentration. Additionally, the tissue slices also capture the pathological complexity of the human prostate and interaction between the cancer and the surrounding stroma. And this is very critical in therapeutic investigations because also the malignant tissue slice cultures proliferate at a similar or lower rates that as in the in situ human cancer, unlike the cells, which are extremely proliferative. So once we had the metabolic profiles validated, then we needed to ensure that these tissues need to be alive and functioning as if in vivo. And so we had to optimize the logistics of using this. And that was performed using a live dead assay. So these surgical specimens were picked up from Stanford University, which is about 40 miles from UCSF, and they were brought to UCSF, kept under culture in this rotating plate that kept the tissues that were resting on titanium meshes in and out of the fluid. And these were processes that were optimized already in Dr. Kiel's lab. What we wanted to look at further is what would be the best time so we can start doing the MR experiments. And so we used live dead assay, looked at the viability over time, and we said that an overnight recovery was essential for the tissues after having been sliced, and we could see dead material sloughing off in the plate. And so after 14 to 16 hours being in culture, they were loaded into our bioreactor. And so what is a bioreactor? It's a precision engineered perfusion system for cell and tissue culture that's been around for many, many decades. It was originally, I think, predominantly used for perfused organ studies. And what this provides is a controlled environment, and it enables real-time quantitative measurements. And so this was a bioreactor that was optimized and developed by Dr. Keyvan Keshari, and we've loaded 4 to 6 slices into the bioreactor on a specially designed cartridge that can be fit into the 5 millimeter NMR bioreactor, and had this continuous perfusion of media, which was well aerated. So there was oxygen levels that could be controlled, and the water and the media perfusion was warmed by a water jacket. And these loops, perfusion loops, was also added on with an injection port where we could add the hyperpolarized substrate when needed. And so we wanted to recapitulate the viability of the tissue. And so we used phosphorus NMR, as has been done historically, to make sure the bioenergetics of the system was maintained. And so as you can see here is a representative example from a tissue slice of cancer grade 3+4. And we can see that the phosphorus spectrum recapitulates what's already been published from way back when Dr. Karanovic did his postdoc here at UCSF with increased phosphomonoesters and decreased phosphocreatine. And we demonstrated that the tissues could be maintained in the bioreactor for up to a 32-hour period. And here is a representative example of the signal dynamics of the prostate tissue slices. This is of primary pattern 3. And the quantification was looked at is summing up the entire lactate area under the curve and taken as a ratio to the total signal of the pyruvate. And you can see that tissue slice cultures of the primary Gleason grade 3 produces more lactate compared to the normal prostate tissue. However, when we looked at primary grade 4, it was much lower, and it like shattered our worldview of things. But then our hypothesis, based on a bunch of other experiments and cancer systems that we had studied in this bioreactor, we knew that we're actually losing some of the lactate signal, because lactate that was produced inside the cell, at least that was our hypothesis, is being constantly exported out. And as this is a continuous flow experiment, the lactate flew away, flowed away. And so we thought we were not capturing the lactate that was effluxed. And in order to validate that hypothesis, we looked at the LDH activity of these tissue slices, and we showed, yes, the LDH activity is much higher, i.e. there should be more lactate being produced. What we then also did, as we were doing the rotary plate tissue slice culture, we measured the lactate that's being put out by these tissues by feeding the media C13 labeled glucose. So the glucose would be taken up by these tissues, converted to lactate, and the lactate that got out of the cell was in the media. So we just sampled the media at 6 hours after the labeling started, and we were able to look at the C13 lactate. So this has to be the lactate that came from the glucose with the C13 label that was metabolized by the tissue and come out. And so we were confident about the amount of lactate that actually is produced by these tissue slices and exported out. And additionally, we also looked at MCT4, which is a monocarboxylate isoform that is associated very specifically with lactate export out of the cell. And we use immunohistochemical staining to quantify this. And we also, again, were reassured that the MCT4 staining was much high. And so we did a little bit deeper dive and looked at these tissue slices of primary grade 3 with a secondary pattern of 4. And we had the pathologist read the percent Gleason grade 4 component, and we mapped it against the lactate to pyruvate ratio. So we can see that with the increase of the pattern 4, there is a decrease in the lactate ratio to pyruvate. And this implied that more and more of the lactate is being effluxed, which also implies increased MCT4 expression, which ties to aggressive phenotype. And this increased MCT4 expression is been shown already that is association with increasing grade and poor prognosis and drug resistance and progression. And so what we've shown here is that with increasing aggressiveness, there's not only lactate production, but also its effluxing that increases. And so armed with this knowledge, the clinical studies, phase 2 trials have been done at UCSF, led by Dr. John Kuranovitz, and correlation to pathological grade. The representative image here shows high spatial and temporal resolution, 3D dynamic HPC13 pyruvate MRI. And what we've shown here is the KPL map overlaid on the proton images. And the regions of Gleason 4+4, 4+3 high grade is associated with high KPL, denoted by the pink regions. And the low grade regions were associated with lower KPL. And so upon further analysis, the KPL is significantly elevated in high grade prostate cancers compared to both normal and low grade disease. And so we've looked at primary prostate cancer, and people who do not undergo prostatectomy, some are the androgen deprivation therapy is the standard treatment. However, the majority of the patients, while initially responding, will inevitably progress from androgen dependent stage to an independent stage, which is called the castration resistant prostate cancer. And so there is an urgent need for us to non-invasively then be able to detect the early marker of treatment response. And using these genomic characterizations that's already been done, we were hoping to characterize the metabolic rewiring and then developed imaging biomarkers. So to achieve this, we used first to look at the metabolic dysregulation with disease progression from androgen dependence to resistance, and then eventually to the neuroendocrine prostate cancer. So we did it using model systems like the cells and the TRAMP mice, and also patient-derived xenografts. And additionally, we then also looked at the neuroendocrine prostate cancer and looked at the metastatic sites in response to treatment. And so as the first project here to identify biomarkers of prostate cancer transformation to androgen independence, we used C13 labeled glucose and glutamine, and used cells and a murine model, which is known as the TRAMP, which is the transgenic adenocarcinoma of the mouse prostate. These were either infused or added to the media, and subsequently we used high-resolution homonuclear, heteronuclear NMR techniques, 1D as well as 2D, to then characterize all the metabolic pathways. And so I just wanted to do a brief overview of the NMR techniques that we've used. We looked at simple 1D proton spectroscopy, where we could look at with and without C13 decoupling, and also the changes in the total metabolite levels. And additionally used two-dimensional technologies such as total correlation spectroscopy or heteronuclear single quantum coherence HSQC technology to look at C13 linked metabolite levels and changes associated with that. And here are the first bunch of results. Looking at just the glycolytic pathway, we showed that in the CRPC cells, as well as in the TRAMP, here I wanted to mention that the LNCAP cells represent the androgen dependent cell line, and the PC3s are typically androgen insensitive cell lines. So it's more signifies the CRPC phenotype. And we also developed in the TRAMP model, the ADPC and the CRPC. Apologies, I think maybe I should just quickly explain in the TRAMP model, we were able to generate this androgen dependent and castration resistant phenotype by orchiectomy and doing a follow-up imaging to look at the progression in terms of the volume of the prostate before we did the C13 glucose. And the androgen sensitive or dependent tumor was designated as those that had a reduction in the tumor volume of at least 20% at the follow-up imaging time point of about 5 days. So defined in the way we did, we've seen that there is an increase in glycolysis in both the cells and the animal models. And there was absolutely no difference in the glucose consumption that we were able to evaluate in the cells. Additionally, we also looked at pyruvate oxidation, i.e. the TCA cycle activity. And we saw that there was an increase in the metabolites aspartate and glutamate, which is in fast exchange with TCA intermediates and thereby a reflection of the TCA cycle activity. We also used TCA Calc, a software that's been validated and used extensively, that was originally made by the UT Southwest group, and showed that in addition to the TCA cycle activity, we noticed that in the GEM model, TRAMP, that the anaplerotic pathways were also upregulated in the castrate-resistant phenotype. And additionally, we were also looking at the use of glutamine as a carbon source in these models, and we saw upregulated glutaminolysis in the castrate-resistant phenotype. And we showed that the TRAMP model is not as glutamine addicted as the cells, because the absolute the difference that we evaluated using the GLS activity was much lesser compared to the model cell lines. And so additionally, we were also able to look at the glutathione pools, which is an indicator of the redox capacity of these tumors. And this was upregulated in the castrate-resistant phenotype. So in summary, what we've shown is that there is increased pyruvate, there is increased conversion of glucose utilization to lactate as glutamate, and as well as glutaminolysis. So we thought any of these probes, such as the C1 pyruvate's conversion to lactate, C2 pyruvate's conversion to glutamate, glutamine conversion to glutamate, and DHA to vitamin C, could be great hyperpolarized probes. These have all been used preclinically and shown viable and feasible, can be used to detect this onset of castration resistance. But then we picked the lowest hanging fruit of hyperpolarized C1 pyruvate and applied these in these two model systems that we had characterized in the cells and in the TRAM, and showed, of course, the KPL, which is the rate of conversion of pyruvate to lactate that we can obtain by, again, using these cells in a bioreactor system and encapsulating it in alginate. And we injected the hyperpolarized solution, and you can see the dynamic production of the lactate signal and the eventual decrease due to T1. And this is the pyruvate hydrate. And this is the actual pyruvate, which is infused in excess. You can see that the KPL is much higher, which is analogous to the glycolytic rate in the PC3 cells compared to the LN cap. And similarly in the TRAMP, which we went through baseline imaging. So we had a baseline hyperpolarized experiment here, and then was re-imaged after 5 days. And these TRAMPs were considered, here is a representative example of androgen-dependent prostate cancer and resistant prostate cancer. You can see that the lactate decreased in those that responded to castration, and those that were resistant, the lactate to pyruvate ratio was even higher. And that's what's also captured here, that although the androgen-dependent prostate cancer, the tumor volume decreased, the tumor kept increasing in the resistant phenotype. Okay. And so this shows that the development of castrate resistance can be monitored by hyperpolarized experiments. Additionally, there's been one case study that's been demonstrated by the UCSF team here in patients, and shows that the hyperpolarized lactate that was captured at baseline before androgen ablation and post androgen ablation, even though there is residual disease in the multiparametric MRI, those were shown to be metabolically inert. You can see that there is absolutely no lactate signal in those after 6 weeks of treatment. And so this again shows us the feasibility of HPMRI and clinical translation of being able to monitor the response to androgen ablation. So the second step is looking at the biomarkers to identify the prostate cancer differentiation to small cell neuroendocrine disease. And with the onset of more potent second-line anti-androgen deprivation, the adenocarcinoma phenotype of the cells transdifferentiate into the small cell neuroendocrine phenotype. And so to do this project, we used patient-derived xenografts where we implanted them as the kidney. We've chosen kidney as the best site for propagation of these tissues because that particular site is extremely well vascularized. And as imaging scientists with dissolution DNP, we found that to be the most convenient site to get our probe in good enough time and without altering the tumor microenvironment or the physiology, whereas in relative to the subcutaneous site, where the tumors, once they get larger, would get really necrotic in the center. And whereas in the kidney, we've never observed necrotic. We worked with many different urologic tumors. And so these mice were infused similar to what we described in the prior project with C13 labeled glucose and glutamine. The tumors were then extracted, lyophilized, and the 2D NMR techniques, the 1D and the 2D that I explained before, was performed to enumerate the different fluxes as well as the steady state metabolites. We chose 3 different adenocarcinoma phenotype PDXs and 4 different neuroendocrine or small cell phenotypes from the LTL and LUCAP series that have been very well annotated. And we looked at, there are differences in the metabolite levels between these 2 sets of PDXs. And we showed that using principal component analysis, myoinositol, taurine, glutamine, tyrosine, and creatine are significant differentiators of small cell neuroendocrine from adenocarcinoma, castrate-resistant prostate cancer. However, these metabolites are much lower in concentration or occur in a crowded part of the proton spectroscopy, rendering that not very useful to look at these metabolites and use it as a biomarker for differentiating in a non-invasive clinical setting. And so we went ahead and looked at the utilization of the substrates, the glucose and the glutamine, and looked at this parameter called fractional enrichment, FE, which denotes the total amount of the poles that originated from the C13 labeled substrates compared to the total pole sizes. So this gives us a metric of the flux of that particular pathway. And again, we looked at the lactate, glutamate, and alanine that arose from the glucose as well as the glutamine. And you can see that lactate is increased, i.e. glycolysis pathway. Glutamate is higher compared to the adenocarcinoma phenotype, as well as the alanine. Additionally, the glutamine labeled studies showed us that the increased glutaminolysis, i.e. the C13 labeling in the glutamate pool, was higher in the small cell neuroendocrine. And once we plugged in some of these data that we get from the 2-dimensional HSQC into the TCA calc system, again, you can see that there are multiple different pathways that are active in the small cell neuroendocrine tumors relative to the adenocarcinomas, where glucose seems to be a diminutive carbon source in these compared to the others, which is denoted by the PDH. And you can see other pathways that the anaplerosis and sometimes the YPC, which is the pyruvate carboxylase pathways, are implicated to be active in these small cell neuroendocrine phenotypes. And so we are currently, in summary, you can look at there is increased glycolysis, TCA cycle activity, glutaminolysis that sets the small cell neuroendocrine phenotype apart from the adenocarcinoma. And these can be followed with the 1 and 2 labeled C13 pyruvate, so could give us viable biomarkers using the HP technology. So we are currently in the process of developing imaging sequences to monitor C2 pyruvate and also applying these in the metastatic models. So just as a feasibility, we also looked at using the C2 labeled pyruvate in the bioreactor tissue slide setup that I had gone through before. And we show that we can simultaneously observe both glycolysis and TCA cycle in these prostate tissue slices, and increased glutamate signal was observed in the more aggressive prostate tissue slices. So as I had mentioned before, this is a continuum disease of the castrate-sensitive to castrate-resistant disease, and from adenocarcinoma to the neuroendocrine phenotype. And with this progression, there is more and more prevalence of metastatic disease. And so the onset of small cell neuroendocrine is a lethal subtype with very poor prognosis of an average of 9 months of life post-diagnosis. And so the selection also of the appropriate treatment of patients with metastatic small cell neuroendocrine cancer is very critical, but is hindered by the fact that neither blood test nor current imaging modalities can reliably identify therapeutic efficacy or even detect the onset of these phenotypes. So we've looked at metastatic models then to recapture the metabolic differentiation that would occur, and also that looking at the bone and the liver. Bone is the second most common site, and liver was considered is known to have particularly poor prognosis compared to other metastatic sites. And also the difference in response to these different sites complicates these. So we are currently now looking at hyperpolarized imaging-assisted co-clinical trials of therapeutic response. And the main motivation of this particular project is to first develop comparable optimal murine imaging protocols in realistic and representative models. So to enable this, first, we've established similar protocols that's used in the clinic in our preclinical scanners, i.e. Two-dimensional, spectrally, spatially selective metabolic metabolite-specific C13 imaging using echoplanar imaging sequence, and propagated these patient-derived xenografts in the murine kidney, and after single-cell digestion, implanted them into the kidney and in the liver. I'm sorry, the bone, the tibia was our choice, and in the liver. And we have also done HP imaging. Here is a representative example of the tumor outgrowth from the tibia. And we've also done CSI approach first to validate our observations. And here is a quick snapshot of the 3 different small cell neuroendocrine PDXs that I had already shown that we had characterized using the C13 labeled glucose and glutamine. We show that although there is no significant difference in the KPL, which is the glycolytic rate assessed by HPMRI, there is a significant difference in the way the tumor grows in these different microenvironments that's captured by the apparent diffusion constant, ADC MRI. Currently, we are now looking at the response of these metastatic prostate cancer PDX models to chemotherapy, which is the first line of treatment upon detection of small cell neuroendocrine phenotype in patients. And what's shown here is the LTL-610 PDX in the liver. At baseline and subsequently at day 7, you can see that the KPL decreased in the treatment and with minimal difference in the vehicle control and the subsequent decrease in the tumor volume relative to the vehicle treated. And similar trends were observed in the tibia. And so what we've shown here is that the HPMRI can actually non-invasively assess response to chemotherapy and has the potential to serve as an early biomarker of response. This is a project that's led by Dr. Evina Mali, and I'm going to have a plug-in here. If you want to learn more about this project, please join us at our HMTRC workshop that is held April 4th and 5th. I also want to end with this slide of the potential of translating using HPMRI to study these metastatic sites of the prostate cancer patients led by the UCSF group here in patients demonstrates a patient with a 75-year-old patient who was diagnosed with metastatic castrate-resistant prostate cancer and several osteoblastic and osteolytic lesions in the pelvis and in the femur. And with HPMRI performed on these, you could see that the KPL was pretty high on these different lesions. And at baseline, it was 0.026, and upon chemotherapy, the KPL reduced to 0.05. So demonstrating the feasibility, first of all, of doing this HP metabolic imaging of bone tumors, and also to monitor the response to chemotherapy in liver. So in summary, I hope I've convinced you that hyperpolarized MRI can not only detect aggressive disease where there is, in addition to increased lactate production, there is also efflux of the lactate. And then with the onset of castration resistance and transdifferentiation to small cell neuroendocrine, tumors have increased aerobic glycolysis, oxidative phosphorylation, and glutaminolysis. And so I hope I've convinced you that hyperpolarized C13 pyruvate can be used to stratify low grade from high grade, detect androgen sensitivity, transdifferentiation, and monitor response. And it's versatile, and the feasibility of clinical translation of this technique has also been shown. And with that, I'd like to acknowledge all the different people that have made the data I've shared with you today possible. And we've been fortunate enough to get plenty of grant support. So with that, open to questions.
Thank you very much.
Thank you so much, Renuka, for this really nice talk. Yes, again, from me, if there are any questions, you can either raise your hand or you can just directly ask the question. There is already one question in the chat asked by Silvia Blanco, and the question is if there's any difference between labeling C1 and C2. So how is this influencing the results?
Could you maybe be a little bit more specific? With labeling on the C1 portion, we cannot capture what happens in the TCA cycle as the pyruvate gets decarboxylated. And so we use combinations of the C1, C2 probe, depending upon the pathway that we want to study. Was that the question?
Yes. That, I mean, I'm like starting on that field recently. I'm studying myotonic dystrophy, but we are trying to assess like a model to study pyruvate to lactate degradation using C13 labeling. But as I'm like just entering to this field, my question was how that influences, and that's what you answered. I mean, how labeling C1 instead of C2, or using the mixture between labeling C1 and C2 could influence the results we are obtaining.
Yeah. So when we do hyperpolarized studies with C1 and C2, I've tried a few different things using dual labeled pyruvate. If you're doing high resolution spectroscopy, it's not a problem, but if you want to minimize the spectral pattern, I've halved the pyruvate concentration I would otherwise use and use singly labeled C1 pyruvate and as a mixture co-polarized with C2 pyruvate also. So they all give similar results. I don't think, so long as you keep the concentration similar in a well-perfused, well-controlled microenvironment, you should not alter the dynamics of the system.
Okay, thank you very much.
Are there any more questions?
I see one more question in the chat from Andreas Berg.
Oh, I don't see it. Can you maybe read it out?
Yes, sure. Thank you for this detailed report on what information on tumor metabolism can be obtained via MRS, also with hyperpolarization. There are two questions. First, can MRS on urine or sperma fluid be used for cancer detection and staging?
I think there've been a lot of work actually done on urine analysis, but since there is no active, not necessarily a component that you could look at HP studies necessarily, but a lot of steady state metabolites have looked at urine and have tried to use it as a marker to differentiate the different stages, but a lot of it tends to be non-specific. I think that's why we're looking at in situ as well. And so that is the one thing that I think we've learned and tried to be more specific of where we are getting the signal from, where we are looking at the metabolism, what ends up in the urine comes from. You cannot tie it specifically to the prostate. There could be cross-contamination from, let's say, the metabolic profiles are could be impacted by any organ.
And the second question is, how relevant is citrate level for PCA detection? So sensitivity, specificity.
With regards to proton spectroscopy, I think it's extremely well established the amount of citrate that's exported out of the cell. So there is huge, if I'm not mistaken, Dr. Kuranovich could correct me, it's on the order of 40 millimolar for a citrate in normal tissue. And that gets reduced to like less than 10 or 5. And so for detection of normal versus malignant prostate cancer, citrate is a very well-established marker. And I can't remember off the top of my head, there's plenty of work that's been done looking at the specificity and sensitivity of using in situ in the prostate citrate levels. And we use it routinely here at our center.
So, thank you very much. I think that answered the question. If not, Andreas, please ask in the chat again.
Okay, there's another question asked by Karen Dos Santos. Yeah, thanks again, Dr. Sriram. Have you also considered or compared the mitochondria transporters besides the MTC membrane transporter? You have mentioned the use of the other potential hyperpolarized imaging probes, such as 5-carbon-13 glutamine and carbon-13 DHA. So what are the pros and the cons?
Oh, we just went for the lowest hanging fruit and something that's already in the clinic for us, because we were very keen on, translating our preclinical findings that can be used in the clinic readily. There are a few issues with the hyperpolarized glutamine and DHA probe that we've struggled with generally as a field. I think for glutamine, very specialized synthesis with deuteration and N15 is required, making that probe quite expensive to use on the preclinical basis, because the probe formulation for glutamine, you would already have a little bit of product, and which is C5 glutamate. So that is the tricky part that we haven't yet fully overcome for this particular kind of application. And DHA, dihydroascorbic acid, which can give you an insight into the redox, is also a little bit challenging on the preclinical model systems, in the sense that the mice become quite sensitive to the DHA and under anesthesia. And so that also requires, Dr. Keshari's group has shown that in awake animals that you could do this experiment much more robustly, but that puts us in a whole nother realm of keeping these mice alive and not move very much in the magnet as we are scanning them without anesthesia. And so those are the two big complications. Yes, a mitochondrial pyruvate transporter is, I think people are realizing more and more the importance of looking at that particular parameter as well, but we have unfortunately not looked into that yet.